Sorry. As I was saying, on the first day, we were able to look at how community pharmacies can engage in making sure that there is vector control and how they can run diagnostic tests in the community. Yesterday, we were able to go through the various innovations that have been going on in curbing malaria. We had the guys from Cambridge talk to us about the plasma check rapid test kits. So today on the last session, we will go through the policies that are imperative in, we'll go through policies that are imperative for community pharmacist involvement in malaria management. And I can see that the speaker for today's session is with us. So before I go any further, I'll welcome Dr. Kanyi, if he's in, to give remarks from HOPAC. Dr. Kanyi, if you can hear me.
Yes, I can hear you. Dr. Imelda,
Welcome.
can you hear me?
Please give your remarks from HOPAC before we start.
Okay. Thank you, everyone, for joining this session. We have had 3 sessions from the 25th of April to commemorate the World Malaria Day, which was on 25th of this month. And we have held these sessions, these 3 sessions in collaborations with African Pharmaceutical Network, who have been gracious enough to partner with us to organize this series to commemorate the World Malaria Day. The theme of this year's World Malaria Day has been harnessing innovation to reduce malaria disease burden and save lives. And we have been particularly looking at how community pharmacists can be more involved in malaria control programs for optimal malaria care. So as Imelda has already said, this is the 3rd and last session that we will be having, and the last 2 have been very informative on how pharmacists, especially community pharmacists, can be more involved in malaria control programs and even providing these services to the patients that we interact with on a daily basis. So I just want to take this opportunity to thank everyone who has joined us for this session. Please stay in the meeting and please remember to subscribe to the meeting on the Pharmacy and Points Board portal for you to get CPD points. And again, just to welcome everybody and to welcome African Pharmaceutical Network, the facilitators as they take us through the session. Karibuni sana. Back to you, Imelda.
Thank you, Dr. Kanyi, for your remarks. So I'll dive right into it. So today's session is on policies imperative for community pharmacists' involvement in malaria management. So despite every step that we will take in reducing the disease burden, we know that it all comes down to the policies and how these policies are and how we respond to them. So today's speaker for this session is David Odhiambo. He's a pharmacist and he's the curator for the African Pharmaceutical Network, and he's also the co-founder of Agriculture, Health and Social Innovation. David is a programs and policy enthusiast with focus on pharmaceutical system strengthening to address global health concern. And I can assure you for this particular session, he's well equipped and well read to address this particular session. So I am sure you're going to learn a lot from this. He passes his time by playing with his wonderful nieces who he loves. So I'll welcome David. Please take over the session.
So much, Kelly. Thank you everyone for being part of this discussion. Unfortunately, I'm not in the best of locations, so I'm hoping my network will be strong enough. And if not, I'll have to switch off my camera. Other than that, I'll just request for the host to give me the capabilities to be able to share my screen as we get into this conversation. And as been introduced, I believe this is a moment for us as pharmacists to shape the future practice, and on this particular occasion, shaping the future practice with a focus on malaria management. And by institutionalizing some of the lessons that we've learned from the first day of discussion, where we are looking at community engagement, social mobilization, diagnosis of malaria, to the next phase where yesterday we were talking about development of innovative aspects, where we're looking at development of actually a diagnostic kit that is already in place for us. And beyond the diagnostic kit, the major bit about the care that we do, which we've not covered in the series of discussion, has been about treatment of malaria. And we know the therapies, artemether, lumefantrine. We have other combinations. Let's say, for example, the artesunate, the quinine options that were there in the initial formative phases when we started the development of these products. So as we look at this for today, I would be key on how do we as pharmacists actually mainstream some of these best practices that we've been talking about. How do we make them stick? And by making them stick, it means they need an institutional backing and a framework that is robust and in place that can shape that future. So on that account, that is why the focus of our discussion will be today. And get into it, we know that policies are guiding documents that shape the future of our practice, and not only the future, but shape how we operate in the healthcare industry. And one of the most regulated industries, other than the weapons industry, has always been the healthcare space and generally pharmaceuticals, because from research and development of products, everything has to go through a robust supply chain model.
Please start working.
Yes. Can you hear me?
I know I've made David host, so.
Please confirm that you can hear me.
We can hear you, David.
Oh, okay. I think somebody was speaking on the backdrop. Sorry for that.
No,
So the main bit I was saying
okay, legit.
So what I'm indicating that from the start of it all, we know that generally the aspect on regulation has been a key bit. And if with that case, then for us in the healthcare space, and generally with this particular focus, the question that we are doing is, how do we then actually ensure that the future practice will be shaped by us? And in this case, with a particular focus on malaria management. And on that account, then as you see my screen, I actually looked into 4 particular documents that are key. And these are guiding documents or policy framework that we think are important and actually are shaping the future of care in terms of management of malaria and even how things are running currently. The first document I'm going to refer to is the Kenya Malaria Strategy, 2019 to 2013. Then in 2020, there was a review, actually a survey that was done that led to the development of the Kenya Malaria Indicator Survey 2020 final report. Other than that, we have the National Guidelines for Diagnosis, Treatment, and Prevention of Malaria in Kenya, which 10, and finally the Health Act 2017. So if we look at these documents from the initial concept of it, we know that 1, there's the malaria strategy, and strategy documents give us the overarching principle of what we intend to achieve, how we intend to achieve it, and then the modalities of making it happen. And the survey is just giving us a context of what has happened. Where are we in terms of our aspirations to realize these objectives that are already coined in the malaria strategic plan? Then the national guidelines is a refinement of the strategy document with particular specifics. Let's say, for example, you are diagnosing. How do you diagnose malaria? We could talk about the rapid diagnostic test kit, that's the antigen based. We can move from the antigen based to the PCR test. We can go to the malaria smear test that we normally have, the clinical serological test and all that. So if we look at all these specifics that are there, then finally the health act, because we know we're existing in a country And as we exist in a country, in a state government that is guided by rules and policies and the Constitution, then following the promulgation of the new Kenyan Constitution in 2010, we had the establishment of the devolved governments and the national government. Therefore, we have two forms of government with shared functions in terms of delivery of healthcare services. And with that in space, then the key thing that we have to acknowledge is that there's a role in terms of malaria management that is left to the national government, strategic direction, governance, and policy, and including financing from a national government perspective. Then on the other end, we have the devolved governments, which are actually key and involved in terms of the community engagement work, because that is where most of the primary health facilities are. That is where the work happens. So there's a number of functions that are devolved to the lower government arms of government, and they have functions that are left to the national government. And that is within the public health sector. But also this goes to the regulation of the private health sector, because as stakeholders, let's say, for example, when you're talking about community pharmacies are within the private sector. And therefore the roles that we're playing in that space within the private sector is still regulated and actually is a contribution to the aspirations and the mandate of the government to provide access to quality healthcare services to its citizens. So the question that we need to be asking ourselves as we go through these policy directives and the kind of discussion that we're having is, one, healthcare service delivery is a mandate of the government. That is the government of Kenya. And the government of Kenya will operate either from a national level or at the county level, following the evolution of the government functions. And then on that, we have a strategic document, 2019 to 2013, that is now breaking our respective responsibilities and objectives in management of malaria. Then we have an indicator survey that is giving us the context of what we've achieved, how we've achieved it, and how we can move from that particular level to our aspirations. And the guidelines is now for the delivery of the specific responsibilities that we as stakeholders in the space, we need to deliver and how we need to deliver them. So picking up from that particular set, then the main document that I'm looking at this particular level is looking at the malaria strategy 2019-2013 that I've just mentioned. And on that one, we have a vision. As I mentioned, the strategy document is giving us an overarching aspiration that we all have in terms of malaria. One is a malaria-free Kenya. And the mission, which is operationalizing that vision, is to direct and coordinate efforts towards a malaria-free Kenya through effective partnerships. So it means through the national government, the Ministry of Health, which is responsible for coordination of healthcare services, their main responsibility would be to direct and coordinate efforts towards a malaria-free Kenya through effective partnership. And the reason as to why I'm looking at it is that we already have some key terms that I mentioned. The key words are partnerships and directing and coordinating from a government perspective. But on the same note, we have a mission vision, which is a malaria-free country. And the goal being to reduce malaria incidence and deaths. And one of the key things that we've been talking about is that the burden of malaria has been high and is still high in our communities because we are losing young people, especially children less than 5 years, and pregnant women to malaria complications because of either delayed diagnosis, delayed treatment, or lack of actually failure of that treatment to be provided to this particular population. So how do we bridge that gap? And on that account, the national strategy is aspiring to at least reduce those incidences and deaths by 75% by 2023 from the 2016 levels that were documented. So how do we go about each and every realizing that mission? These are now where we get to the specific objectives. And when I'm talking about this particular slide, I'm going to be specific on terms of, we had our discussion first on community engagement, social mobilization, advocacy to the particular level. Then now we know the treatment, the therapeutic component, that is our forte as pharmacists in terms of therapeutic management of conditions. Then the next bit of it is looking at the diagnosis that was now presented yesterday when we're talking about the inversion of the plasma check. So when we talk about the objectives, actually integrating and looking at how can we as pharmacists in our areas of practice collaborate and work with the national government to actually mainstream to position ourselves as key partners, key allies in delivery of these services. One, the first objective is to protect 100% of people living in malaria risk areas through access to appropriate malaria preventive interventions by 2023. Then on that account, we already see their first role is prevention through protective measures. We're preventing malaria risk. And to reduce that risk, one of the key things we know, vector control is a key area. Do we have fumigation, spraying of in-houses, even communication on how to wear long sleeve clothing in the houses in the evenings especially. The use of insecticide-treated mosquito nets. What is our role in that space? To be able to support the government to achieve that 100% in malaria risk areas. And we know we talk about the endemic areas, we talk about the seasonal regions where we have the fluctuations in terms of the temperature and the humidity conditions, and the low risk areas. When we talk about the high risk, in the Kenyan demographic, we'll be looking at the western region of Kenya, then we'll look at the coastal region where we have the higher burden of malaria. Then the seasonal areas, we're looking at the western highlands where we talk about Elgon region and all, then even part of the Rift Valley, Kericho areas. So how do we actually ensure that we are able to ensure that these people who are at risk are protected from malaria through the insecticide-treated nets, spraying and disinfection, vector control, social mobilization, and behavior change communication activities. So that is how we need to be thinking about it. The second objective from a policy perspective is to manage 100% of suspected malaria cases according to the Kenya Malaria Treatment Guideline by 2023. And that is focused on treatment. And if we look at the policy imperatives and policy direction is that for any particular condition, we need to be able, for malaria specifically, we need to be able to, one, test. After testing, we need to treat. And after treating, we need to track to actually ascertain that the treatment has been effective, and we know that people are getting better from the outcomes. One of the key things that have been noted is that treatments are being initiated, especially where we don't test or where we test yet. The treatment might not be effective because we all know there's an emerging antimicrobial resistance that is growing across the area space, especially even with malaria products, the AL-based therapies. So for management of suspected cases, our role as pharmacists will come from the rapid diagnosis. We can deliver rapid diagnostic services and actually to confirm that it is malaria. Once we do that, the next phase for us in terms of intervention would be, can we treat majorly with uncomplicated malaria? For the complicated malaria, we can offer supportive care in the initial phase and offer referral services. The aim is to ensure that 100% of suspected malaria cases, according to the Kenya Malaria Treatment Guidelines, are treated by 2023. And that would be the mission. And our role in that place is to ensure diagnosis, we can play where we can play it, we do it. Where we cannot diagnose, we refer. In treatment, we need to be able to treat. Where we can't treat, refer. Then we ensure that that care is being delivered. The third bit in terms of the objectives, establishing systems for malaria elimination in targeted counties by 2023. And when we talk about malaria elimination, majorly these we are looking at the low-risk communities, the low-risk regions. And that would be, for example, we're talking about central Kenya, where we know the prevalence of malaria is minimal. And most of the times when we get cases of malaria in such regions, including Nairobi, is because there is an imported case. Maybe somebody was traveling from Kisumu, from Taita, from Mombasa, Kilifi, Malindi, and they're coming into Nairobi, but they had already been infected. But then the presentation of the infection is when they are ready in this particular location, and therefore they need to be treated. And the aim is to ensure we eliminate malaria in these particular countries that are targeted by 2023. How do we achieve that elimination? One, if somebody is planning to travel, let's say, to a high-risk area, we need to be able to provide prophylactic therapy. That we could talk about the mefloquine, doxycycline, primaquine, and related. So what are the prophylactic drugs that we can provide? If we are able to do that, then it means imported cases will not exist. With no imported cases, the transmission, even when they come back, will be limited because of the reduced risk of transfer and importation of infections, which is a win for all of us. So can we take a role in terms of prophylaxis? In that case, for people who are hoping to travel, because we know we're all mobile individuals. The other big point, number 4, increase utilization of appropriate malaria interventions in Kenya to at least 80% by 2023. We're hoping to achieve all the hundreds, but the utilization of all appropriate malaria intervention, that is from preventive to management and even to referral where it's necessary, and ensuring we have robust policies that are actually ensuring these aspirations are being realized. That should be by 2023. And in that case, when we talk about it, what is our space? And we look at the entire continuum of malaria interventions and service delivery. Then strengthening malaria surveillance and use of information to improve decision-making for program performance. And when you talk about malaria surveillance, it's getting the data of how many patients do we deal with. And that is actually pointing to one of the key discussion points that I'm mentioning, and I think I'll also add when we're getting to the next steps, is that we all know the burden of malaria. We all as pharmacists know that whichever location or station that we practice in, we are delivering quality services, which is a good thing. But as we are delivering quality services, do we document, do we actually use that information to relay to the policymakers to ensure this is captured and is guiding the next course of interventions? And even if not from a policy perspective, if as David, I'm running a pharmacy or a clinic somewhere, and I found a number of cases that are presenting, there's a new trend that I'm determining. How is that determining that data, that information, relay healthcare system managers to be able to actually inform the government interventions and to inform practice by people who might be in the neighborhood so that we improve on our systems delivery? Those are some of the key things that we need to be keen on and looking at. When we talk about malaria surveillance, when we talk about diagnosis, once you diagnose, if we're saying we can diagnose at the pharmacy level, are we able after that, during the diagnosis, actually upon diagnosis to document and report that to the national government, the data collection system, the health information system? Once we've treated, how many people have we treated? What is the response level? So that at least we have that data captured. Because even when I was reviewing the guidelines, there is a reference that we are aiming to reduce by at least 75% of the malaria burden from 2016. But there's no clear number of the people who had suffered from malaria in 2016 that is mentioned in the document. So how will we actually ascertain that we've achieved that target unless we have the data? And that is where another role that is coming for us in terms of providing that data and making it available. The last bit, providing leadership and management for optimal implementation of malaria interventions at all levels for the achievement of the objective by 2023. Leadership and management. We need leadership in terms of guiding, mobilizing resources, managing projects, and everything that involves it. And therefore, that is where, as pharmacists, we need to be asking ourselves, how do we go into that space? How do we take charge? And actually, how do we ensure that all that we champion for, all that we commit to deliver in promoting access to quality malaria healthcare services and optimizing malaria care delivery is realizable? And with that, as we discuss the objectives and we look at the touch points on what can we do, how can we do it, then we need to ask ourselves, what would be our key interventions in care delivery, and what does the policy currently space dictate or talk about? And the reason as to why I'm talking about this particular aspect is that these are the policies and they're going to shape practice for up to 2023. They're unlikely to change, but in 2023 or 2022 towards the end, there will be a review of this policy. If pharmacists as stakeholders, we don't take an active role and we don't get involved in these particular policies, then it means we might be playing a critical role in addressing some of these global health challenges, including malaria burden, but we are not innovative enough in terms of how we present our case. We are not being integrated into the policy making processes, and we are not informing those policies to position ourselves as strategic allies. Because one of the key things that we've acknowledged in the mission is to ensure the ministry establishes those collaborative partnerships. And those partnerships are key to ensure we achieve the mandate of this particular policy. So when I looked at these particular guiding documents, we had the strategy document, as I mentioned. We have the index report 2020 survey. Then we have the diagnosis, management, and treatment of malaria, the guidelines. Then finally, other than the guidelines, we have the Health Act. When you look at the first document, the strategy document, at what point is pharmacy mentioned? One, at the Procurement and Supply Chain Management Committee of Experts. And the purpose of that committee is to provide overall stewardship on malaria commodity management. And it is not pharmacists, it is Department of Pharmacy, which means that is at a high leadership level. So do we have that coordination happening at a leadership level on how many of us can drive that conversation? Yet from the discussion as we started on Monday, we've seen key touch points on key interventions that we can drive and actually lead the conversation in ensuring we improve access to malaria care from prevention to management and actually ascertaining positive health outcomes. Because we know that is our space and we can do that from. The second mention on the strategy document is in case management committee of experts. And actually the purpose of that particular committee is to advise on policy issues related to diagnosis and treatment of malaria in Kenya. advising on policy, and the other one is overall stewardship on malaria commodity management. So it means out of the entire scope of what we are looking at, the probable areas where we can practice in terms of the touch points, as highlighted in the objectives, only 2 are being captured, and it is through the department. And as we acknowledge, some of these departments might have a pharmacist and some might not. And when having the representation, then you're not involved, then it means even the activities that we are practicing, the services that we are discharging as pharmacists in our areas of practice are not being captured at the policy level because somebody representing the Department of Pharmacy might not be a pharmacist or even a pharmacy professional at all. And therefore, they are not able to relay constants and actually the best practices that are coming from our end. So those are key things that I needed to highlight on that. Then the next document that I looked into, for the other ones, the guideline that is straightforward, the Health Act, just disaggregation of the roles of the government. But when we look at these, the second document, the indicator survey, and this is saying it's a contextual assessment of the current status as of 2020, as was documented by the ministry from that survey that was done. The mosquito nets, we talk about preventive aspects in terms of service delivery. 0.7% of the people who were surveyed obtained their mosquito nets from pharmacies. And being they obtained their mosquito nets from pharmacies, it means there's a critical role that already was being played. But when you look at the policy document that is guiding the delivery of these services, there's no mention of nets to be distributed through pharmacies and even any pharmacy mention aspect. So already we are doing something, and that survey is pointing to a point that actually the survey is pointing to a direction that actually pharmacies are doing something in this space. Mosquito net, 0.7% of the 7,543 people who are surveyed in terms of the access to mosquito nets. So that is one pointer. The second pointer, source of advice or treatment for children less than 5 years with fever. Normally we know based on our context, when somebody presents with fever, the first suspicion, the clinical suspicion is malaria. And from differential diagnosis, in case of that kind of a case, then they would seek malaria treatment and support. From the evidence that was generated from the indicator survey, 17.8% of 359 people who were interviewed, those who had children less than 5 years, who sought services for fever, that is either advice or treatment, were served by pharmacies. So from a strategy perspective, a policy directive, we don't have a role and it's not captured other than from the departments of pharmacy. But in terms of the service delivery that is coming from evidence that is captured, 0.7% of nets are distributed through pharmacies. Source of advice and treatment for children less than 5 years, where we have the substantial burden of malaria, is 17.8% by pharmacies. So that is already showing us there is evidence for us to do something. So when we look at that, then the question that we need to be asking ourselves, what is the way forward? And how do we shape policies? I know we would all wish to shape policies where pharmacies are running almost everything. It would be a wish, but it's not feasible. And we have to acknowledge that we are working with other stakeholders. The best way to sell our case is one, to get the evidence that is necessary. And therefore, the first phase of the conversation that we're having, and actually these are some of the things that are driving factors behind us coming up with this program and looking at how do we deliver it and make it be impactful in shaping the future of how we can deliver services as pharmacists. One, we need to have ongoing research on the role of pharmacists in the primary healthcare. And in this case, in the primary healthcare, with a focus on malaria, and this would be operational research in terms of operational research or implementation science, in the sense that as a community pharmacy, what services are you delivering to your community in terms of malaria control? Are you recommending use of treated mosquito nets? Do you have them in stock, or do you find a way to distribute them or even referring them to obtain them from primary healthcare centers? If you do, how many people do you refer on a weekly basis? That is something that needs to be documented. Then the other bit would be in management, diagnosis. How many rapid diagnostic kits do you have in stock? How many do you dispense or even use to test patients who present with symptoms of malaria on a weekly basis? Do you document that? Once you've documented them, how many are confirmed cases? How many are negative that are considered for another differential diagnosis? So if you've confirmed that, you've documented that information, it's already we are gaining the data that we need and generating the surveillance information that can actually even inform the ministries of health in implementing their work. Then from the treatment, some of them might present with complicated malaria. We are not able to intervene at that level other than supportive care and referrals. How many people do we refer? and what is the referral pathway like for us as community pharmacies. And in the initial conversation, I remember the first email, I shared what the vision would be for community pharmacies, pre-practice, and establishing a service charter. And in that service charter, the key is, as a community pharmacy, what are the needs in the community we are serving? And once we've acknowledged those needs, do we actually highlight the specific services we can offer? Who are the probable collaborators? Then we design that model that will deliver solutions to the people. With that generated evidence, operational research component, we need to document everything. And that is one key thing that I've already acknowledged and mentioned a couple of times. Documentation is key. When I'm talking about diagnosis, how many did we diagnose? It has to be documented and relayed. So that when we're talking about our key role as pharmacists in delivery and management of malaria in the different practice settings, we have evidence to back that claim. Then the next thing is, we know policy direction is in malaria management is around testing, treat, and track, which is a good component. And therefore, that is where we now plug in and see how can we test? Yes, through the rapid diagnostic test. Then once we test, we can treat. Where we can't treat, we refer, but we also track to see the positive outcomes to ensure everybody is achieving the positive outcome that we wish for. Then finally, we have to actively take up our space in malaria management, that is from diagnosis, treatment, referral, community engagement, social mobilization, and policy advocacy to actually stamp our authority and deliver on these. And as we do these, as we're talking about policy advocacy there, we all know that we need to be in policies, but we need to have our interests represented in policy and guiding documents. Then we need some of us to take those spaces. How do we get involved? Generate evidence, participate in the different country focus groups and stakeholder forums. We have professional associations, for example, at this particular level. We have HOPAC that represent the pharmacies, clinical pharmacists working in the hospital setting. Are you a member? Are you sharing some of the best practices? Are you collating and actually generating a position statement that can guide the government in a policy direction? Once that is generated and actively presented, then that informs the next step in terms of what policy are we going to put in place? What key stakeholders do we have on board? Unless we get engaged in the policy level, we have our representation, our interests might not be taken care of. Reason being, nobody knows what we're doing and nobody actually presents it in the discussion table. So first, we do the work in the initial phases, they're getting the evidence, document that evidence. Once we document the evidence, we get our focus groups, our strategic focus priority, like I would say the platform that we're using to engage in driving these interventions. Then we make them stick, we make them take action. And one of the key things that I remember from the day one conversation with Dr. Sultani Matendechero, he was talking about advocacy, community engagement, and social mobilization, ACSM. And that is where I mentioned the aspect that we have community civil society organizations, NGOs, community-based organizations that are doing different activities in the communities. And they normally have engagement focus groups with the counties where there are any policy interventions and all that. And as I mentioned from the Health Act 2017, there's the national government role and the county government role. Can you plug into this stakeholder focus group? Can you have lobby group that you can engage with in the community level to shape the conversation? And as we do that, we're shaping the future of care, we're shaping the policies. And as much as we'll be talking now, let's say, for example, next year when we have the same kind of a webinar series again, or another kind of engagement in terms of looking at the place of pharmacists in malaria management, we will not only be talking about what we can do, but we will have evidence of what we are doing. And three, being next year will be 2023, where we are hoping this particular policy will be reviewed, the strategy. Then we have evidence to shape that policy. And we are assured that then as we move forward, it's becoming institutionalized that as pharmacists in our practice setting, we are allowed by law to diagnose malaria. We are allowed by law to treat malaria. We are allowed by law to be able to run community health programs, including the spraying, as some of us were mentioning in day one, including the actually stocking of these insecticide treated nets. We know that most of these are delivered through the government facilities. But as much as they deliver through the government facilities, how many people are taking the mark from there? If there are not so many people, can we then use our special purpose vehicles? Let's say, for example, HOPAC, Pharmaceutical Society of Kenya, the KPA for the Farmtex who might be in the room. Can we use those special purpose vehicles and actually structure engagement with the ministry department that is responsible for malaria engagement, and purpose to partner with them. Because the policy, actually, spirit of the policy is that we have to have partnerships. Purpose to partner with them to deliver on these solutions. And as we partner with them, we have an addition of value that we're offering, that already we are doing this and we think we can do it better. Already some people are coming to our pharmacies who've been seeking mosquito nets, but being delivered through the government facilities, we might repurpose and actually see how can we support in the supply chain management of these. And we know pharmaceutical supply chain, healthcare products, technologies, and supplies management is a critical component and one of our strengths as pharmacists. Can we take up that role? And it would actually open gate for us to explore and take advantage of other avenues that are happening. Because I just remember there's a conversation that we're having today in terms of competency. And one of the facilitators of a session was presenting on what are the advances that are already happening in the UK in terms of government support, rebate services, and financing solutions that are coming. How do we build a case to be seen as allies rather than outsiders in the conversation? Because we know we have a role to play. We are in our communities. The people being affected by malaria are our allies, are our colleagues, and our parents and our siblings or our children in the community. How do we serve them better? And as we serve them, how do we make it sustainable? And then we work together to drive that agenda forward. And I believe from this particular conversation, we understand what the policy looks like, what are the evidence that has already been generated from a policy document that actually a government document, and what opportunities exist for us in delivering malaria care. Then ultimately, based on the activities we can do, we have what we need to be doing now, then shape that to inform the next set of policies. And with that, we'll institutionalize this and make this the future of our practice, where we are not outsiders, but rather members of the team driving access to malaria care services. Thank you. And that marks the end of my presentation. I'll leave it back to you, Kelly, for the Q&A session.
Thank you so much, David, for such an enlightening session on policies. I think from the previous conversation that we had on Monday and today's conversation, it's clear that we need an enabling platform for all the pharmacists, so that once we gather this information and we have this platform to air our thoughts and make this possible, we can move forward to realizing the strategy, the 2019 to 2023 strategy of reducing the number of malaria cases in Kenya. So I only have one question for you, and then I'll invite the audience to ask any questions that they have. In this engagement of community pharmacists in policies, what's the business imperative for them? What should they expect or at least have in mind when they, actively participate in making policies or making policies come to work in the community pharmacies? What's their business imperative?
If I think I got you right, looking at the business aspect of it, what is the business case for anybody to engage in this kind of malaria work, looking at it majorly being driven by the government, right? I hope that is the case. So in that case, then the question that we need to be asking ourselves, what is the business sense of it for us as pharmacists and as stakeholders in the healthcare space? One key thing that we have to acknowledge, as much as we would want to deliver, we have our own needs, and that is the financial bit. And we need to ask ourselves, how do we make that happen? One key thing, community engagement, social mobilization, and vector control activities as they happen in their communities. We all know that currently there's conversation actually in every other corporation in the world talking about ESG principles, environmental sustainability and governance principles, which are key. So what do you stand for as an organization? It's likely for an individual to do business with a company that stands for something than a business that stands for nothing. So if that's the case, then already you're positioning yourself as a reliable trustworthy, and actually credible partner to work within the community. It therefore means even in the community where you're working, individual stakeholders would be keen to partner with you and to deliver the healthcare services with you and buy your products in your pharmacy if you're running a pharmacy, which is a one good case, because that will be like you actually opening up your market pool. So you have more people who will be seeking services from you. That is a key bit. The second bit of it is looking at the aspect that I've just mentioned in terms of operational research and looking at how to institutionalize these particular services. When you're doing diagnosis, let's say you have rapid diagnostic kits, they're being bought. And even when you had this presentation yesterday, the team from Cambridge were talking about selling the rapid diagnostic kit for around 60 to 100 shillings, depending on how they're being sourced. But majorly their focus is delivering to the government facilities through KEMSA. On that case, then it means you as a pharmacy, if you're able to offer the diagnostic services and they are made a standing service that can be obtained from the pharmacy, one, the members of the community who will want to be tested for malaria will be willing and able to pay for that service. You already have a new service stream other than waiting for somebody to be sick to buy just medicines. They'll be tested, which is the good key case. Now from the government directly, we need, like, the best practice is to test, treat, and track. So you're able to test. That is a good thing for you. After testing, if they're not suffering from malaria, you'll not waste your medicines recommending antimalarials when they don't need it. Therefore, you'll look at alternatives and even refer them where necessary. If they have malaria, that is a case where you can now treat them actually with antimalarials, which is still a business case for you because you have a medicine that you have to sell to someone who actually needs it, which is a key bit as well. For the research component, as I mentioned about it, we know there are different grant projects that are being driven and even research projects. Can we establish through the special purpose vehicle that I was talking about, can we bid for grants that we are testing a new model of practice that would position us as service providers in the community pharmacy or even in the pharmacy space to address malaria? That would be an innovative model of practice because we see community pharmacies and pharmacies as primary healthcare units next to our communities, our people. Therefore, if we can do a research there, then if that grant funding or even from partnering with other companies who are willing to fund such kind of research, as a participating member, you can raise the revenue from there, which is sustainable for you. And other than the revenue that you're generating in terms of the cash received, you're doing research, positioning yourself as a credible healthcare professional through the generated evidence that you're shaping that industry. Three, other than that, you're now actually generating evidence. That evidence is to inform policy, as I mentioned. If it informs policy, the government, if you're going to be supporting in the distribution of the, let's say, mosquito nets, through the special purpose vehicle, the professional associations and related, can we lobby to get a facilitation fee in terms of how do we manage the supply chain? What is the cost of that management? It will be paid to the participating pharmacies that are helping deliver that. That's already a win because you're now having an extra revenue stream. The same would apply to therapeutics in terms of management of malaria. Who is managing them? Is there financing that is coming for you to be able to support the government on that? Then the last bit, we know healthcare services, even in the public hospitals, the financing mechanism for the government has been through the allocations, that is the budgetary allocation. And other than that, for these purchases, it is through KEMSA and NHIF, maybe NHIF also paying for the services that people use once in at every one point when they get into the hospitals, the capitation model. So if we already see that you are delivering a critical public health service, then we can lobby for the National Hospital Insurance Fund to actually enlist these pharmacies as primary healthcare facilities with capitation for you to serve in management of malaria, even if it's not the 200 shillings that the government facilities get, let's say 50 shillings, for a number of patients who are within the risk group in that particular population, you'd be generating a revenue. And other than that generation of that revenue, you're establishing a new model where we are supporting the government and working collaboratively, and it's even supporting the government to improve access and uptake of the National Social Insurance Fund. And that is one of the key things that actually we are currently looking at and reading through on the NHS in the United Kingdom. There's no private insurance in terms of the health. The major focus of it has been the social insurance, NHS. So how do we kind of replicate such best practices, but integrate it by looking at what models of practices do we have, what are the needs of our community, and make business sense for you, and also make value proposition to the partners you will need to hope to work with and drive that together. I hope I've answered you, Kelly. Any other question? Any
Yes, you
concerns?
have.
Thank you.
Thank you. Thank you. So far so good. I'm not seeing any questions from the audience. So I think now we've come to the end of this 3-part series webinar, and it's been very enlightening for those who have managed to attend all the 3 sessions. So thank you so much. I would like to thank you for making time to be with us today. Then I'd like to thank HOPAC Kenya for partnering with us to make this happen. So I'll invite Imelda of HOPAC to give a few remarks, and then we can close up the session. Imelda, can you hear me?
Good evening. My name is Yukabeth, stepping in for Imelda. Thank you so much, APN, for partnering with HOPAC to be able to deliver this CPD. This series of webinars, we've been able to learn a lot about malaria, beginning from day 1, day 2, we went to diagnostics and therapeutics, and today we've looked at the policy, how we can come in, what our role as pharmacists can be. And I thank you because now you've even told us next time when you're meeting, next year when we are meeting, we'll not be talking about what can pharmacists do, but we will be talking about evidence. What are pharmacists currently doing with regards to promoting education, patient awareness for malaria, carrying out diagnostic activities, and also managing therapeutics, and also as an eye opener to community pharmacies, a way to be able to get revenue from it. So mine is just to remind us that these meetings are all on the PPB website. Feel free to subscribe so that you're able to get the points later when they'll be emailed to you, and to also do announcements for today's meeting. So up close, we are going to have our ophthalmology workshop, which is going to be on the 5th of May. It will be a half-day event at Lions Eye Hospital. We hope to see all of us there. It will be on the 5th of May. Kindly take note of that. And this information will be found on your emails as well. And then after that, we'll have management of common illnesses. That will be on 11th of May. And then thereafter, we'll have our anticoagulation workshop. So we hope to see you in person. These meetings we're talking about are going to be in-person meetings. We hope to see you there. Kindly mark the date. Anticoagulation workshop will be at Radisson's Blue, while the ophthalmology workshop, we hope to see you at Lions. That's next week on the 5th of May. This has been a pleasure from HOPAC, the entire HOPAC team, national office. This has been a pleasure it's always a pleasure to be able to deliver CMEs and to be in line with our vision of promoting best standards in hospital pharmacies, in hospital pharmacy practice and beyond, because we now know that pharmacies are involved in primary healthcare. So even in community pharmacy, we do promote best standards. At this point, I'd like to wish everyone a good night. The Radisson's Blue date, I'm seeing someone is asking me to repeat. Yeah, finally the screen is there. You're able to see there the Radisson's Blue date is going to be on the 8th. Are you able to see the screen? Can someone from the meeting confirm?
Yes,
you can see.
Oh yeah, so those
Yes.
are the dates, and you'll be sure to see them on our platforms, on the website, and even on the WhatsApp group. That's when the events are happening. But before the Radisson's Blue one, we are going to be at Lions. Anyone who's taken Lions Eye Hospital have a lot. If you are interested in ophthalmology, or you'd like to know, you actually do not know what a pharmacist can do, that's the place to be. That's the event you're going to have first on the 5th. I hope to see all of us there in person. It's been a pleasure. At this point, I'd like to thank the people who've made this series, APN, David, and Kelly. It's been awesome having you, and the awesome secretariat that HOPAC has, Dr. Imelda and Dr. Emily. Thank you for the good work that you've done, and I wish everyone a good night. See you in person on the 5th.
Thank you, Yukabeth, and Thank you on behalf of APN for making this happen. I'd also like to thank the participants for taking your time to attend all the three sessions. Just a reminder that we will have recordings of all the three sessions on our YouTube channel. That's African Pharmaceutical Network. So you can always go back and listen through the recordings. You can also refer to your colleagues in the profession to listen to the recordings. And so thank you. This has been a great session and very enlightening. We hope this will be one of the many webinars we have on various sessions as we go through the year. So have a lovely night, everyone. Thank you.
Thank you everyone for the opportunity. Have a good night and let's engage in the coming days. Thank you. Bye.